This is Clinical Conversations. Everyone knows about the increasing role of nurse practitioners and physician assistants in clinical life, but measuring that increase has been difficult. A group of researchers set out to do that, using a commercial database focused on office-based physician practices. They report their findings, which focus chiefly on NPs, in the June issue of Health Affairs. We'll discuss those findings with the report's first author, Dr. Hilary Barnes. Dr. Barnes is a health services researcher and a family NP. She's an assistant professor at the University of Delaware School of Nursing. Welcome to Clinical Conversations, Dr. Barnes.
Thank you. Thank you for having me.
Using a commercial database that details physician-led practices was SKNA was the name of the database. You looked at roughly a 10-year span from 2008 to 2016, and you measured two main things: the growth in the presence of NPs in physicians' primary care practices, and secondly, the difference in growth between rural and non-rural areas, right?
Yes.
Okay. And so, briefly, what'd you find?
Well, we found that in these practices, there's a growing presence of nurse practitioners, and nurse practitioners are constituting a greater proportion of primary care providers in both rural and non-rural settings. We actually found greater growth in rural settings, and NPs were constituting a greater proportion of primary care providers in rural primary care. We also found that practices were employing more NPs, so more NPs were more practices were adding NPs to their clinical staff in primary care in both rural and non-rural settings.
Okay, and interestingly, the proportion of physicians in those practices dropped over the survey period as the number of NPs rose, but the PA's numbers remained stable as proportions. So, are the new clinicians inevitably taking ownership of primary care?
I don't know if it's exactly new clinicians taking ownership of primary care, because nurse practitioners and PAs have been around for decades. But I think there's more interest and acceptance of the value of nurse practitioners and physician assistants that they provide to a primary care setting. And so more practices are embracing using them to improve access to care, to deliver care, particularly in changing healthcare models. So as healthcare reform continues to move forward and the way practices are paid, it makes a lot of sense to bring in these other providers to create this kind of well-rounded healthcare delivery model.
Yeah, you're right. I mean, those clinicians have been around for decades. What I meant to convey is that the role, their primary role vis-a-vis physicians is beginning to come to the fore. For instance, I've been reading a book called Reverse Innovation, writing about using third world innovation to inform practices in the first world. And one of the things that they're doing is they're being very parsimonious about using physicians and increasingly putting the burden of primary care on non-physicians. And so that may well be happening here. I mean, you yourself in the article point to the increasing interdisciplinary character of primary care.
I haven't heard of the book that you read, so that's actually pretty interesting. I think there are other things at play too. I think that patient demand has increased, so more people are seeking primary care, and healthcare has become more complicated, so bringing in more providers. But there's also a large debate surrounding provider supply. So it's harder to get maybe like physicians into primary care where, and in some of these areas such as rural settings, whereas the supply of physician assistants and nurse practitioners is a little more readily available to move into these settings and provide excellent primary care.
The name of that book again is Reverse Innovation. So you found that the fraction of practices, and you've said this with NPs, and the number of NPs per practice both rose.
Yes.
Do you see that increasing? Have you looked at the SKNA numbers since you published your article?
No, I haven't. I haven't looked at the subsequent years of data, but there is recent research out there, not in this study, but there is research out there showing that the supply of physician assistants and nurse practitioners is going to continue to increase in coming years.
Okay.
But I don't have the SKNA data to look at that.
Okay. There were some paradoxical findings, at least it seemed paradoxical to me. The states allowing restricted or reduced scopes of practice for NPs showed faster growth than the states allowing full scope of practice. So comment on that, if you would.
Okay. There are a couple things that we think might be going on. So in these analyses, we looked at the states in each of the categories had been in their had their scope of practice legislation for the entire time. So nobody changed out of a category during that time. So I'll first say that, so it's a steady sample. Mm-hmm. The full scope of practice states, in these states, nurse practitioners also have the opportunity to work in nurse managed health clinics and some independent practice. Yeah. So we wonder, and that data is not in, we weren't able to look at those numbers in these data, but we're thinking that some of that provider supply in those states might not be captured in these data because they have other opportunities where they can work.
Yes.
Whereas in the reduced scope of practice and the restricted scope of practice states, a nurse practitioner has to work with a physician. So they have to be connected to that person by a collaborative agreement. And it could be the greater growth could be that the supply is greater of the NPs. These physician practices in those states are noticing and understanding and appreciating the value that the NP brings to healthcare delivery, so they're adding them to their practice. The greater growth that occurred in those reduced scope of practice states where the nurse practitioner still needs to be connected to the physician, we kind of hypothesize that greater growth is happening in those states because the nurse practitioner can actually do more in those practices, where the restricted scope of practice states, the restrictions on practice are greater. So when they're brought into the practice, what they're allowed to do or able to do may be limited. So they might not be as, I don't want to say useful, but like their efficiency as an employee is not to the maximum in those practices. Uh-huh. So the growth may be a little lower in those states compared to the reduced scope of practice states where they have to be attached to the physician, but they have more ability to do more things. They can practice at a higher level. And so as an employee or as a healthcare provider, they're more efficient and there's greater value to their employment in those practices. And so these practices may value more bringing them in because they can do more and add more to the practice.
And the thing to keep in mind, as you point out, is that you studied physician-led practices. And so there is a little bit of bias there in those states where there are no restrictions on what a nurse practitioner can do. Then those practices are not even captured in the SKNF data.
Exactly.
SKNA
right.
data. I'm sorry.
Yeah, and SKNA. Then there's so MPs, yeah. So MPs working outside, maybe more in an independent capacity, are not captured in these data. And then nurse managed health clinics, like I mentioned, those exist in most states. So those aren't captured either. So that's so MPs could be there, but the highest percentage of practices that have nurse practitioners are in these full scope of practice states where MPs really can work to top of their education and training. They're most optimized in these practices.
Okay, so as a working NP and as a researcher, what surprised you about your findings in the health affairs paper?
I think, well, you pointed it out. I think the thing that surprised us the most was this greater growth in these reduced scope of practice states, mm-hmm. Compared to the full scope of practice states. These are just descriptive analyses, so we didn't test any hypotheses. Right. It would be really interesting to find maybe like what's going on within these practices that make the practices in these states maybe more interested in hiring MPs. But those trends over time in the scope of practice states, those greater growth in the reduced scope of practice states is actually pretty interesting. And we were pleased to see that there's greater presence of NPs in rural settings because some of the in rural settings oftentimes will have access issues. Patients will have access issues. So having these providers in those settings will help improve access. It's encouraging. It's encouraging for patients.
So you were encouraged by that growth. What's your research focus these days? What are you looking at without disclosing too much? Are you working on other surveys like this, or?
I am. I've just started another project looking at using this data, these SKNA data, and looking at the practice level and then looking at patient outcomes based off of whether a practice has a nurse practitioner or not. So we're building our data set, we're kind of developing our statistical models to kind of see if having the nurse practitioner changes different outcomes for patients, or if they have different outcomes for patients when a patient is seen in one of these interdisciplinary practices.
Okay. And so what do you wish would happen to primary care?
I would like to see more primary care, more practices using nurse practitioners. I think it will be really important going forward for some of these states that have restrictions on nurse practitioners. I think it will be really beneficial to them to remove scope of practice restrictions for NPs so NPs can easily move into primary care. If I may reference an older study of mine that I published last year.
Sure.
Is that okay?
Sure.
We actually found greater presence of nurse practitioners in primary care when the state allowed for full scope of practice. So in this study, we looked at full scope of practice compared to states with any restriction. And we ran some statistical models, and there was a greater likelihood that a nurse practitioner worked in primary care in these states with full scope of practice. So removing these scope of practice restrictions is a really great way to kind of optimize the workforce, the nurse practitioner workforce, and move them into those areas where they're needed. And nurse practitioners provide excellent primary care. Outcomes are great for nurse practitioner delivered primary care. And I think primary care is a great place. I think I would like to see nurse practitioners really move in and kind of work with other providers, physicians, and everyone else in the healthcare system to really kind of move primary care forward. And not to say to take over primary care, but really kind of as a really good, robust part of the workforce to kind of augment and improve primary care delivery.
Okay. You mentioned at the end of your paper there is a graduate nurse education program ending, and it's ending this month. And is that going to cut into the number of NPs who are going to be able to afford the extra training? I'm
not sure about that. The graduate nurse education demonstration was developed out of the Affordable Care Act, and it provided money to 9 different sites. So one site was out of the University of Pennsylvania and included 9 satellite schools in the area, or 9 other universities in the area, and then there were 4 other sites around the United States. So it didn't encompass the full country. So most NPs are still kind of funding their education the way they had been. But in all these sites, they found that these schools were able to increase the number of NPs they were able to educate through receiving this federal money. Right now, I think there are plans and there's a debate surrounding kind of keeping this program going and funding nurse practitioner education the way physician residency programs are funded through federal funds.
Right.
And for your own information, there was actually perspectives in the New England Journal about 2 weeks ago from Linda Aiken, who led this the University of Pennsylvania portion of the GNE, the Graduate Nurse Education Demonstration, and she wrote an article or a perspective piece talking about this and how we need to kind of increase the funding for nurse practitioner education and support nurse practitioner education to build the primary care workforce.
Well, I've told you about a book you didn't know about, and you told me about an article that I should have read. And so fair trade. Thank you.
You're welcome.
I want to thank you for talking with us today, Dr. Barnes.
Oh, you're welcome. Thank you very much.
That was our 222nd edition. All earlier conversations may be found at podcasts.jwatch.org, where you can leave comments on this conversation. Or you can contact me on email. That's JELIA@NEJM.org. We come to you from NEJM Journal Watch. Kristen Kelly is the executive producer here for the NEJM Group. I'm Joe Elia. Thank you for listening.